All right, welcome back, everybody. Today we're talking about Chapter 5 and how to develop emergency operation plans. So we'll go through some of the details of what goes into those, the history of those, and what they mean for preparedness planning efforts. Emergency, emergency operation plans, or EOPs, define the scope of activities and division of responsibilities for responding to hazardous events. Developing and continuously refining them is a core component of emergency preparedness across organizations and at all levels of government. Effective EOPs are built through stakeholder engagement involving assessment, priority setting, analysis, testing, and ongoing refinement. These are living documents. We need to keep looking at them, testing them, and making them better. For stakeholders, EOPs provide a shared framework for decision making before and during emergencies. They allow organizations to evaluate response options in advance, clarify roles and trade offs, coordinate across jurisdictions, and adapt quickly during real world events. At the national level, FEMA supports state, local, and tribal governments in developing jurisdiction-wide EOPs that address not only government functions but also the broader community and social systems essential to effective emergency response. In addition to jurisdiction-wide planning, many organizations are required to develop facility-level emergency operations plans as a condition for their funding, licensing, or accreditation. These requirements apply across a wide range of settings like hospitals, clinics, schools, child care facilities, housing authorities, critical infrastructure operators, and some businesses. Public health agencies play a bridging role between jurisdiction-wide EOPs and facility-level plans by ensuring that public health risks and consequences are fully integrated into emergency plans at all levels. They help guide, review, and approve facility-level EOPs, support partner agencies in updating their own plans, and lead or support emergency response activities for incidents with significant public health impacts. These responsibilities are operationalized through the activation of public health emergency operations centers and are reflected in CDC defined public health preparedness and response capabilities. So this connects back to what we were talking about before with CDC capabilities. We need to be able to make these EOPs, these emergency operation plans, connect from county level operations to how those integrate with specific facilities and organizations who each have their own emergency operations plans that depend on one another. We're looking at this visual here. This chart shows how emergency planning happens within each sector and across agencies horizontally. They might work together on broad plans, but then each facility, you can see on the right hand side there, those those work on their own individual emergency operations plans that connect to the jurisdiction and public health plans at the local level. Counties often work with these local facilities like hospitals to help them integrate their individual plans into the broader county plans, and the county emergency managers, they might actually review the hospital emergency plans and approve them, and help them improve those plans so that they connect better with the county plan, and that each of those partner agencies knows what to expect from each other during an emergency. Emergency operations planning draws on decades of planning theory and practice, which FEMA has consolidated into its comprehensive preparedness guide. This guide outlines a set of core steps that support the effective development of an EOP, including 6 steps that apply directly to public health agencies. A critical first step in this process is identifying and engaging stakeholders who will play roles in the development and the implementation of the EOP. For public health, these stakeholders usually fall into 2 groups: external partners like emergency management, healthcare, EMS, human services, and then internal partners within the health department, including epidemiology, laboratory services, communicable disease control, environmental health, and informatics. Planning typically begins with a small core planning team that has broad knowledge of these stakeholders and is responsible for coordinating engagement and guiding the larger process. As part of emergency operations planning, the THERA process provides a structured way for planning teams and stakeholders to identify the hazards and risks most relevant to their jurisdiction. We talked about this last time in Chapter 4. THERA supports hazard and capability assessment, and emergency management partners are often key contributors to this because of their experience of these assessment frameworks. Once threats are identified, planning teams assess existing capabilities by drawing on multiple sources, including after-action reports from exercises and real events, preparedness evaluations, and external performance data. Public health agencies also use tools like the CDC's Operational Readiness Review, which supports in-depth evaluation of emergency response operations, and the National Health Security Preparedness Index, which offers an external comparative view of preparedness across states and counties. We talked about that as well. You saw those different scores for that index across states and counties to gauge how well prepared they were for different threats. Together, these resources help EOP planning teams assess strengths, identify gaps, and prioritize improvements from multiple perspectives. Identifying operational priorities for a public health agency during an emergency is a critical step in preparedness planning. Priority setting requires weighing the effectiveness and impact of agency functions, the resources required to carry them out, and the consequences of reducing or suspending certain activities. Equally important is incorporating the needs and preferences of the community into this process. Actively engaging community stakeholders ensures that priorities reflect real world concerns and values. Once priorities are established, planning teams translate them into clear goals and objectives that guide response and recovery efforts during events. Once priorities and objectives are established, the planning team, working with key stakeholders, identifies a sequence of actions needed to achieve each objective, along with clear roles and responsibilities for agencies and individuals. This step focuses on practical implementation, including identifying potential obstacles, relevant facilities, and the resources required to carry out each action. To support this process, planners often use analytical tools such as process flow maps, implementation diagrams, and decision trees. Like, if this happens, then we do this. These tools happen, these tools help teams explore alternative implementation options, anticipate contingencies. Like, if this happens, what would this happen? What would this result in? Ensure that plans are both realistic and actionable. We don't want these plans to be, you know, fictitious works where we're not going to actually be able to apply them to real emergency situations. After priorities and actions are defined, the planning team integrates the results into a coherent written operation plan, circulates it among those key stakeholders for feedback. So we got this plan now. We want to share it with everyone to get feedback to make sure it's on track. This stage benefits from multiple rounds of review and revision to ensure clarity, feasibility, and alignment. Once finalized, the plan is submitted for formal approval by public health leadership and partner organizations, then broadly disseminated to operational staff. In our jurisdiction, for example, in Riverside, we actually have to finish the plan and then submit it to the Board of Supervisors, which is the governing body for the county. Once they sign off on it, then it becomes an active plan. The planning team also plays a critical role in training, education, and ensuring that staff understand the EOP and have the knowledge and skills to implement it. So especially we don't want this document to just sit on the shelf without people reviewing it and actually putting it into action. An effective emergency operations plans, like I said, is not static. It doesn't sit on the shelf. It's always evolving. It requires ongoing cycles of testing and updating through exercises, drills, and real-world responses. To improve feasibility and reduce disruption, agencies often use focused, repeated simulations that test specific components of the plan over time, rather than using it, rather than testing everything at once. Pick apart a specific component and test it out. After each exercise or event, after action reviews or reports, AARs as they're often called, play a critical role by identifying strengths, gaps, and areas for improvement. These findings are then used to update the EOP, ensuring that the plan remains a living document, evolving with practical, relevant, and effective solutions for future emergencies. There's a widely used emergency planning framework, including the FEMA's Comprehensive Preparedness Guide. It recommends that every emergency operation plan follows a standardized structure. Using common EOP components helps ensure consistency, improves usability across agencies, and reduces the risk that critical information will be overlooked. So that means if you work for one organization, you can easily drop in during an emergency and an incident command situation where you can see what another agency has developed. It should be fairly easy to anticipate where things are within the document due to this standardization established by FEMA's Comprehensive Preparedness Guide. At a high level, an effective EOP clearly defines its purpose and scope, describes the planning environment and hazards facing the jurisdiction, and outlines key planning assumptions, and then explains how response operations will function through the concept of operations section, clarifies roles and responsibilities, establishes systems for direction, coordination, information sharing, and communications. Finally, it addresses administration, finance, and logistics. ensuring that legal authorities, mutual aid, staffing, and resource management are all in place. Together, these components allow the EOP to translate preparedness planning into coordinated actionable response. Using a standardized set of EOP components offers clear advantages for emergency preparedness. Standardization allows users to quickly navigate large, complex plans. I mean, these are 100-page documents, so they have to be organized really well. During time-sensitive emergencies, supports coordination and interoperability across agencies, meaning that a lot of agencies will have very similar looking plans to help, increase the ease of understanding for everybody who's involved. They all operate under using a all hazards framework again. For public health agencies, EOPs must also reflect that their unique emergency operations responsibilities. These responsibilities are outlined in the CDC's Public Health Emergency Preparedness and Response capabilities. We talked about those before, particularly Capability 3, which is Emergency Operations Coordination. This capability defines how public health agencies assess their incidents, activate emergency operations, develop response strategies, manage and sustain operations, and ultimately demobilize and then evaluate how they did. Together, these core functions ensure that public health can effectively coordinate with emergency management partners, support health and medical response, and continuously improve preparedness through evaluation and corrective action. In many states, territories, and local jurisdictions, public health agency leaders hold the legal authority to declare public health emergencies and issue certain public health orders. Like, for example, our health officer here in Riverside, he's appointed by the Board of Supervisors. He has the legal authority, and the scope of the authority allows the health officer to declare public health emergency when it's applicable. The scope of this authority varies by state and local law. In jurisdictions where these powers are not directly delegated, public health agencies play a critical advisory role to elected officials such as governors, mayors, or county leaders. Because of this variation, public health emergency operation plans must clearly define the conditions under which emergency declarations or orders are justified and explicitly identify which officials are responsible for making those decisions. Public health agencies have the authority to activate and manage a public health emergency operations center, either as a dedicated public health EOC or as a public health function embedded within another governmental EOC. The EOC, Emergency Operations Center, whether physical or virtual, is the central hub for coordinating response and support activities during emergencies. Dedicated public health EOCs are especially important during events with widespread or severe public health consequences, where disease control, mitigation, and recovery efforts become the primary response strategies. Public health emergency operations plans clearly define when and how these EOCs, these emergency operations centers, are activated, ensuring a timely and organized response. Public health agencies play a central role in ensuring emergency operations plans are aligned across organization and levels of government. Horizontally, They review and approve facility level EOPs so hospitals, schools, and other partners can coordinate effectively during emergencies, sharing information, resources, and implementing public health orders. Vertically, public health agencies align their EOPs with federal, state, and other local plans, including clear protocols for requesting and providing assistance across levels of government. Effective public health EOPs also remain consistent with related plans such as preparedness, continuity of operations, continuity of government, mitigation, and recovery plans, ensuring that a coordinated interoperable response before, during, and after emergencies. So again, plans, emergency operation plans developed by public health response, they have to integrate with other partners, like I said, with hospitals and other other agencies, making sure that they're aligned with similar goals, and then we also have to align those plans with agencies above us so that when we request resources and everybody is on the same page both above and across. The National Preparedness System defines how public health agencies contribute to emergency response at the national level. Its modern legal foundation comes from Presidential Policy Directive 8, which established a coordinated system spanning 5 mission areas: prevention, protection, mitigation, response, and recovery. Remember, this goes back to that chart that we had in a previous lecture showing how all these different national systems interact with each other, frameworks. Within this system, the National Response Framework outlines how disasters are managed and organizes response activities into emergency support functions. Emergency Support Function 8, or ESF 8, specifically addresses public health and medical services. Under ESF 8, public health agencies are responsible for functions such as issuing health warnings, conducting surveillance, managing medical surge, providing public health and medical consultation, responding to vector-borne threats like mosquito epidemics, and addressing environmental health risks related to air, water, food, and workplaces. Public health agencies play a central role in overseeing medical and mental health during emergencies, and these responsibilities are formalized in public health emergency operations plans. Because states and territories have broad legal authority to regulate medical practice, public health agencies are key decision makers in determining when emergency orders or regulations are needed. So when do we need to declare an emergency? When do we need to regulate? Schools are closed, those type of orders. Those are all defined within the emergency operations plans as particular measures that can be employed. During declared emergencies, states may use emergency powers to expand healthcare workforce by relaxing licensing requirements, allowing retired or out-of-state providers to practice, and authorizing a broad range of professionals to perform tasks like testing and vaccination. So during major emergencies, the state can relax, licensing to allow people who may not have had the ability legally to do things before now have the right to give vaccinations, or we need extra staff to help out. We need to get people out of retirement, retired doctors and nurses back into the workforce quickly. Those rules can be relaxed to allow, to help out with that surge capacity. States can also activate crisis standards of care, which allows providers to triage patients, adjust staffing ratios, and allocate scarce resources ethically to minimize population level harm. For example, like during day-to-day operations, there is certain requirements that there has to be a certain number of nurses. You guys probably know this from your own experience, some of you, that there are required numbers of nurses per patients, patient provider ratios. Those can be relaxed during an emergency so that, legally speaking, providers can have more patients under their care. Importantly, these standards provide legal protections for providers who follow them and are guided by state-developed ethical frameworks that facilities can operationalize locally. Emergency operation plans are inherently dense and complex documents. They lay out many activities, assign responsibilities across many organizations and partners. They specify detailed conditions for when and how actions should occur. In any given emergency, however, only a small subset of those actions is actually relevant. Under time pressure and resource constraints, users often struggle to navigate and extract what matters most. Even with strong training and exercises, unrealistic for responders to retain full working knowledge of every plan element. Because the EOPs are static free text documents, they can't dynamically analyze different combinations of actions or adapt in real time. Updates happen periodically, not during unfolding events, which limits their usefulness for decision support, especially during novel or rapidly evolving emergencies. Converting a static emergency operations plan, basically a big manual on somebody's desk, converting that into an electronic decision support system requires breaking the plan down into core building blocks. Instead of treating the EOP as a long narrative document, each discrete action becomes a data element stored in a searchable relational database. Actions are tagged to objectives, hazards, triggered conditions, responsible entities, and required resources, allowing these elements to be linked and queried dynamically. Once structured this way, decision rules can be built. Essentially, if-then logic then specifies when actions should be triggered, what resources they consume, and how likely they are to achieve desired outcomes. By assigning numeric thresholds and parameters to these rules, the system can support real-time decision-making rather than static reference during emergencies. So technology is definitely going to help us take some of these documents that used to exist as, sit on somebody's shelf. There are tools now, and the way you structure the document can be built to allow people to search for specific information. Maybe AI can be helpful in this space as well by being able to grab specific information by request. I'm facing this particular type of scenario. What do I need to do in this situation? Those type of things can be more easily found out of the big, dense emergency operation plan. Emergency operations plans, these decision support systems, they become far more powerful and they're linked to real data about risk and capabilities within a jurisdiction. Public health agencies can import information from prior risk assessments, surveillance systems, health information exchanges, surveys, web-based emergency assistance platforms. These data streams can allow plans to move beyond static assumptions and reflect current conditions. Like, this is what's happening exactly right now based on this data. How we help our responders make the right decisions for this particular scenario. National data sources such as vulnerability resilience preparedness indexes can be layered with local data to strengthen situational awareness. That's basically, what's happening right now. What does our data tell us about what we are seeing? Situational awareness. Once integrated, these data are translated into parameters with decision rules like if this happens, then do this, allowing the system to support more informed, timely, specific decision making. Once an emergency operations plan is converted into a data-driven decision support system, modern analytics can be applied to support rapid evidence-based decision making. At a basic level, users can quickly query the system to identify the most relevant actions based on the hazard, the objectives, and responsible entities. At more advanced levels, artificial intelligence and optimization methods can evaluate many possible combinations of response actions and rank them based on likelihood of success, resource use, and uncertainty. Over time, these systems can be improved using data from real emergencies across multiple jurisdictions to refine decision rules. However, it's critical to recognize limitation. Data-driven systems can reflect underlying structural inequities, particularly for low resource historically marginalized communities. Ongoing testing and bias mitigation are essential. Emergency operation plans are critical tools for public health agencies. They guide preparedness and response before, during, and after, and across hazardous emergency events at local, state, and national levels. Their true value lies not only in the written plan, but in the collaborative process used to develop them. One that engages stakeholders in assessment, priority setting, analysis, testing, and continuous refinement. Public health agencies play a unique and essential role in developing and aligning these plans across sectors, and their effectiveness depends on regular use, evaluation, and updating based on real or simulated events. Increasingly, agencies are moving beyond static documents toward dynamic decision support tools that leverage modern informatics, data science, and machine learning. So basically, we're moving a lot in a new direction with emergency operations plans into a more dynamic environment where these concepts of an emergency operations plan are moved into a data system, a decision support system, and these things are only as good as the partners who are involved in the process. Really, it's about getting everybody together and going through this and practicing these activities together, identifying collective resources, and making sure that the document itself is not the focus, but rather the process of developing it and working together to get there. All right, that ends chapter 5. We will hit chapter 6 next. Thank you.